Welcome to part 6. This is Charles Clinton. Chapter 19, Summary, Physiologic and Pharmacologic Maneuvers and Biopsy in Cardiac Catheterization. What about physiologic maneuvers during exercise? You can put a catheter in this patient and make this patient exercise. Remember that exercise increases demands. This increases peripheral oxygen saturation, increasing cardiac output. Cardiac output has to increase to keep up with demands. In normal hearts, cardiac output suffices. In dysfunctional hearts, the lower cardiac output has a problem because you have to keep up with the demands, which are high. This means a higher peripheral oxygen extraction, meaning a lower mixed venous oxygen concentration. What are normal values? An exercise index more than 0.8 and an exercise factor more or equal to 6. The exercise index is the relationship between a linear relationship between cardiac output and oxygen consumption. If we know oxygen consumption, we could estimate what the cardiac output will be. So it should be more than 0.8. Exercise factor is that for every 100 ml oxygen consumption increase, the cardiac output should increase 600 ml. 600 over 100 is equal to 6. Supine exercise, which is one of the preferred exercises when you're evaluating hemodynamic parameters, has some nuances. In the early phase, there is an increased stroke volume. Why? Because there's an increased left ventricular end diastolic volume, which leads to a higher preload. In the late phase, there's a decreased stroke volume, and the main what maintains cardiac output here is the increase in heart rate. Where are these measures useful? In heart failure with preserved ejection fraction, in mitral stenosis, and valvular regurgitation. For example, you will see different parameters as elevations in left ventricular end diastolic pressure, pulmonary capillary wedge pressure, pulmonary artery pressure. You can see a fall in stroke volume. You can see a fall in the exercise factor or the index. And all this will be helpful evaluating the physiology of the patient. What about physiologic maneuvers in hypertrophic cardiomyopathy? When you are straining, in the straining phase, there is a decrease in venous return. This decreases preload. And as a consequence, the left ventricular outflow tract gradient will increase. Then there's other options here with rapid volume loading, also seen with inspiration. You can volume load this patient, or you could make this patient inhale profound inhalation and see the hemodynamic changes. This can unmask pericardial constriction from myocardial restriction. We will see it next. In this illustration, what we are seeing is the venous tracings. So in the normal CVP, lower left, for example, is this left-sided or is this right-sided? This is right-sided. Why? Because the A wave is much taller than the V wave. And on the left side, the inverse occurs. Why? Because on the right side, you have the superior vena cava and the inferior vena cava decompressing that fill-in, that V wave of the right side. Going back to the topic, a sign that is somewhat differential between tamponade and constrictive pericarditis is the square root sign. Look at the tracing for constrictive pericarditis. After the V wave, you have a steep decline in pressure. Look at the cardiac tamponade tracings. You see an A, you see a C, you see a steep X, you see a V, but where is the Y steep decline? There is none. That is what happens in cardiac tamponade. That is a main distinction. Square root sign isn't only seen in constrictive pericarditis. You can see it also in restrictive physiology. What about the Kussmaul sign, upper right? Kussmaul sign talks to you about increased ventricular interdependence. So patient with tamponade, patient with restrictive or physiology, with constrictive pericarditis, what's happening? That when you inhale, more volume is coming into the right, but you have a non-compliant heart, and this means that there is backflow into the jugular veins, and that's why you have an increase in the tracing during inspiration. What is Pulsus paradoxus? It is the same thing, only that we are seeing the reflection of the Kussmaul sign in the systemic arterial circulation. What are we seeing in Pulsus paradoxus? You are seeing the systemic blood pressure fall of at least 10 millimeters mercury during inspiration. It also talks to you about ventricular interdependence. Why? Because when you have this filling in a non-compliant heart, you are making this right side try to engorge with blood, pushing the interventricular septum a little to the left. The filling on the left will decrease, and this means a decreased cardiac output, and decreased cardiac output is part of the blood pressure formula. Here you can see restrictive versus constrictive physiology. An important point I want you to see here is how the pressure time curves change between restrictive and constrictive, meaning that you can differentiate both in the cath lab. Why? Because with restrictive myocardial disease, there is, during inspiration, there is a fall in the ventricular and the pressure tracing for the left ventricle and the right ventricle. While in constrictive pericarditis, due to the high interdependence which is manifested and aggravated here, you can see a decrease in the left ventricular pressure tracing and an increase in the right ventricular pressure tracing during inspiration. What are other maneuvers for pulmonary hypertension reversibility? You can use nitric oxide if you have a pulmonary capillary wedge pressure that is under 18. If it's over 18, you have to change. If it's under 18, use nitrous oxide. It's a vasodilator, fast inactivation with very shallow or nil systemic effects. Give 80 parts per million. A positive vasodilator response means a mean pulmonary artery pressure decrease at least 10 millimeters mercury to an absolute value under 40 millimeters mercury without a fall in cardiac output. If the pulmonary capillary wedge pressure is over 18, we're talking that the left side of the heart has increased pressures. So if you give this patient a pulmonary vasodilator, this will send more blood to the left, and the left is malfunction or dysfunctioning, and you will increase the risk for pulmonary edema, and you don't want any lawsuit. So you'll give this patient sodium nitroprusside, which has a larger effect reducing afterload, and it will also help reducing afterload on the left. That is why you should start off with 0.25 to 0.5 micrograms kilogram minute and increase it until your PCWP is under 18. What is a positive response? When you reduce pulmonary vascular resistance at least 20%. Now, talking about hypertrophic cardiomyopathy. Remember, you always want to elicit increase in pressure gradients. If you elicit this increase in pressure gradients over the threshold, you know this patient is at increased risk. So if you were not able to do this with Valsalva, with exercise, with different methods, use medications. What increases the gradients? Isoprotenolol. On the illustration, upper illustration, there you can see the pressure volume loop. With isoprotenolol beta agonism, you increase inotropy. So there's increased contractility, and this might increase the gradient. With nitrates, you decrease the preload. So nitrates produce vasodilation. If you decrease preload, so there's less liquid in the left ventricle, so gradients will be increased. And how can you decrease the gradient? With phenylephrine. Alpha agonism increase afterload, so the left ventricle would have to fight a greater pressure to expel the blood from the heart, which would mean the gradient would be diminished, because remember that a gradient is a difference in pressures between chamber A and chamber B. What about endomyocardial biopsy? Its main use is for monitoring rejection after cardiac transplant. Class 1 indication are for both directed for giant cell myocarditis. You want to know if this patient has giant cell myocarditis and if you can treat this. So you want to see if he has fulminant heart failure or acute heart failure that isn't explained for any other reason. Go for the biopsy. All the other indications are class 2 indications. For example, if you think the patient has toxicity, cardiotoxicity due to anthracyclines, go for this. If you think the patient has sarcoidosis and you don't have the diagnosis, go for the segment that was affected in that echocardiogram. You should take 4 to 5 samples, each at least 1 millimeter. And complications are various. It could go as high as 6%. The perforation with tamponade is pretty low, less than 0.1%. And the complications vary from embolism of air, of clots, perforation, arrhythmias, fistulas. If you have a patient with a left bundle branch block and you're going for a biopsy, be careful don't catch that moderator band, because remember that the right bundle branch passes through it. And that is it. Nice summary. Pretty enthusiastic. Happy. Hope this helps you out. And if not, it will help me out while I'm on my elliptical studying for this. Thank you.